So I'm going to talk about the miscarriage, lessons for correct diagnosis and management. We meet women at the emergency department with bleeding in early pregnancy that have or not have lower pelvic pain. We can also meet women that are regular viability control of the pregnancy. And in those cases, we can find an intrauterine viable pregnancy. Some women turn to have a miscarriage. Some turn out to have an ectopic pregnancy. So I'm going to talk about a particular miscarriage in this lecture. So how do we diagnose miscarriage? Of course, patient history is a very important item here. So we have patients that probably know the time of the last menstrual period, and we know that the history about the vaginal bleeding and about the pelvic pain. But of course, we have to do the diagnostic. So first, what we do is a clinical examination. So during clinical examination, we might find pregnancy tissues in the vagina. We might see the open cervix. We might see the heavy bleeding without visible pregnancy tissues. But for clinical examination, is important to assess what is going on with the patient and where in the stage of the early pregnancy the patient is. And of course, the ultrasound is playing a very important role in this. So how do we know that miscarriage is an ongoing? For the ongoing miscarriage, we will see pregnancy products in the vagina. And of course, we might see them in the cervix. We can see them protruding through the cervix. And if we do not see any tissues, but we have a patient history with the heavy bleeding, with the clots, so we might see or palpate the cervix open. First, before talking about the miscarriage and ultrasound, we have to talk about the viable intrauterine pregnancy. It is very important to know how early pregnancy looks like for each gestational week and what structures we have to assess when we look at the early pregnancy using ultrasound. So, of course, what we look at the gestational sac, we look at the shape of the gestational sac, we look at the yolk sac. We can see and assess the shape and the presence or absence of the yolk sac. And then we look at the embryo, if we see any embryo. And we also have to assess the amnion, which is also an important structure, particularly for the prognosis of the early pregnancy. So knowing all these structures and knowing what the normality of these structures at ultrasound is essential when we assess women with early pregnancy. So here you see several viable pregnancies with ultrasound different from gestational week. So in my lecture, I will show you several ultrasound images, and I just want to talk about the orientation of my ultrasound images. So in order for you to orientate, my images will be orientating like this with the anteverted uterus and with the urinary bladder in front and the pouch of Douglas in behind. So if we look here, we see the thickened endometrium, we see the trophoblast around, and then we see the gestational sac with the yolk sac inside. Here we can see also a small embryo, and of course this is not a video, but we might see also some activities in like heart activity in that. Then we can also see look at the yolk sac, and of course assess the location of the pregnancy, which is also very important in the assessment. So we have to locate the pregnancy as well in the uterus. So here you see series of the normal intrauterine pregnancies, and here as well with advancing gestational age, we can also see the measurement of the crown rump length of the pregnancies depending on which week we are. And of course in larger embryos, we can see also the heartbeat at ultrasound. So what about the prognosis at ultrasound? There are some signs that might say that this woman might have a poor prognosis for this pregnancy to successfully develop. And when we look at the gestational sac, it could be irregular or low located sac. Of course, maybe low implantation, but if we do not see particularly if the pregnancy is viable and we have a low located sac, we might suspect that the sac is on the way out from the uterus, going to be expelled. Then we look at the amnion, and amnion should be approximately the size of the embryo. So if amnion is missing, if we see that amnion is too small or too large, which means that larger than the CRL, then it's not normal amnion, and it might be a sign of the poor prognosis for this pregnancy. Then we also assess the fetal heart, and we know that fetal heart should be above 10, about 100 beats per minute if the pregnancy reaches 6 weeks. There is some biological variation, of course, but if we see a low heart rate that is below 100 beats per minute and the pregnancy is at least 6 weeks of gestation, we might consider it being a sign of poor prognosis, even if there is some heartbeat. And of course, the yolk sac could be too small, too big, missing, or irregular. We do not measure it, but we can just assess it visually and see the morphology of that. So these are the signs that might be considered for poor prognosis in early pregnancy. So here are some cases for you where we can see that there is this is a gestational sac. We can see the yolk sac, and we see the amnion and small embryos. You see, this is the too large amnion in this case, and this pregnancy, even with the small hyperechoic structure considered to be embryo without heart activity, what could be considered being poor prognosis. We will talk about the criteria for diagnosing miscarriage, for conclusive diagnosis later during this lecture. And again, here we see a larger embryo. We see the embryo without any heart activity. Of course, this is a clear sign. We have quite large serial in this case. Here we see the irregular yolk sac in this particular case. So for the ongoing miscarriage, of course, our clinical diagnosis is very important, but of course, sometimes we can also see the situation at ultrasound. So here we can see the cervix. This is the cervix, and we see the cervix is open. So here is the content clots, where pregnancy tissues protruding into the vagina and also leaving the cervix. So this patient was heavily bleeding during ongoing miscarriage. And of course, we have no circulation in the tissues, so it means that we have no viable tissue in this case. So how do we know if this is a viable or non-viable pregnancy? So again, we can assess the structures, but for the conclusive diagnosis, we have to have some criteria. So what do we have to look? Shall we look at the size of gestational sac? Shall we rely on CRL? Or do we need always to see no heartbeat in the embryo? First, let's look at the gestational sac, and let's look how to measure the size of gestational sac. Here again, if you use the mean diameter of the gestational sac to diagnose a non-viable intrauterine pregnancy, we need to know how we should measure the gestational sac. Here we have quite a huge gestational sac, and this is empty gestational sac, but to know, we need to know if there is a miscarriage, we need to measure it. So we should take 3 measurements that are perpendicular to each other, and we measure twice in one direction. Thereafter, turn the transducer with 90 degrees and measure the third diameter. And then, of course, we add them and divide in 3, and we have a mean diameter, or MSD, for the gestational sac. So some of people are making these 3 measurements in different ways. So we take one horizontal view, and some doctors are measuring twice in the vertical. This is not correct. Because why? Because this measurement is the same as this measurement. So don't measure in this way. Again, measure in this way for your 3 measurements in order to get a correct mean diameter of the gestational sac. It will be very important for your diagnosis of the non-viable intrauterine pregnancy. Can we look at the growth of the gestational sac or growth of the embryo to diagnose a miscarriage? Of course, we do follow-ups on these pregnancies, and we measure the size and we assess has there been any growth or not. However, we cannot rely on the mean gestational sex. So here is a study that was published before the new criteria of miscarriage have been proposed. So they included intrauterine pregnancies of uncertain viability that had empty sac and no embryo with mean gestational sac diameter below 20 or below 30 millimeters, depending on the center, or embryo without heartbeat with CRL or below 6 or below 8 millimeters, depending on the center. It was a prospective observational study. So they have recruited 1,060 patients, and 359 of them came for a follow-up scan because the aim was to compare these two scans. And out of these, 460 had no yolk sac and no embryo, so they were empty sacs. 419 had yolk sac but no visible embryo, and 179 had embryo but without heartbeat. And the scan was repeated in 7 to 14 days later, and the outcome was the viability of the pregnancy at 11 to 14 week scan. So let's look at the change. So what we look here, we look at the change in an MSD, which is mean diameter of the gestational sac, and at a change in CRL, crown rump length, between the first scan and between the growth. So this is the difference, the change in the diameters. And if you see the blues are those of the viables at 11 to 14 weeks, and red are non-viables. And as you see here, particularly for MSD, there is an overlap in growth rates between the viable and non-viable pregnancy. That says that there is no cutoff for the growth of mean gestational sac diameter, below which viable pregnancy could be safely excluded. So don't assess the change in mean gestational sac diameter between the two examinations in 7 to 14 days because of the biological overlap. And if we look at the cutoff value of CRL, so CRL growth of 0.2 millimeters a day was also always associated with a miscarriage. It means that if we have very slow growth, 0.2 millimeter a day, it is always associated with miscarriage if we repeat a scan in 7 to 14 days. So how should we define a non-viable pregnancy? So again, based on the same patient group, 1,060 patients, out of these 473 were viable and 11 to 14 week scan, and 587 were non-viable at the scan. And in here it was assessed the size again of the mean gestational sac diameter and of the CRL. And if we could look here at the cutoff values for mean gestational sac diameter, if there was no yolk sac and no embryo, to predict the viability, we can see that if we check, for example, 16 millimeters of mean gestational sac diameter, the cutoff that has been used for a while, for a long time ago, we can see still that we still have false positives. So it's 4.4% of patients will still have a viable pregnancy. And we reach the 100% specificity, which means 0 false positives at the 21 millimeters in gestational sac. Of course, sensitivity is very low in this case, but if we look at the specificity, which I think is the most important, because we do not want to miss any viable pregnancies and treat them as miscarriages, it was reached at the 21 millimeter in diameter of mean gestational sac. And if looking at the pregnancies where there was a yolk sac but there was no embryo at the scan, to predict viability at week 11, 14, again we can see that 100% specificity, no false positives were reached at 21 millimeter of mean gestational sac. What about CRL? If we look at CRL, we can see if we choose cutoff between 4 to 5 to 2 millimeters, we will have 8.3% of pregnancies that are false positive, 1 out of 10, still be viable. So the 0 false positives were reached at 5.3 millimeters of CRL. It means that this is the cutoff where in the study no viable pregnancies were found after that cutoff of the CRL. So we have to look directly to this paper about the inter-observer agreement for the reproducibility of gestational sac measurement and coronal plump measurement at 6 to 9 weeks. And we can see that if we look at the limits of agreement for CRL, so inter-observer agreement was 8.9 and 11.4%. And for inter-observer agreement, it was plus minus 14.6%. But if we look for the gestational sac, inter-observer agreement was plus minus 18.8%, almost 19%. What does it mean? It means that if we measure a mean gestational sac, if it's measured, for example, at 20 millimeters by the first observer, prediction interval for the second observer would be between 16.8 to 24.5. It means that the second observer would measure it in this interval. And for CRL, if we say that CRL is 6 millimeters, the interval for the second observer would be between 5.4 to 6.7 millimeters. This is where the measurement of the second observer would be put. So it means that we need to have a range, or we need to increase the cutoff for both MSD and CRL in order not to miss the viable pregnancy and treat it as a non-viable pregnancy. So again, therefore, we go back to the first paper. Therefore, based on the inter-observer variability, and it has been concluded that Canada chauvinistas are unsafe, and recommendations were to use a cutoff of mean gestational sac diameter of more than 25 millimeters, which it means in the correct measurements, as I show you, if we use mean the diameter out of 3 perpendicular diameters. And also for CRL, if we see an embryo, it should be more than 7 millimeters without any heartbeat as a cutoff for non-viability. And this is to minimize the risk of false positive diagnosis of miscarriage, and of course, patients that are mistreated and viable pregnancies interrupted. So just to repeat, diagnosis criteria for non-viable pregnancy today are empty gestational sac, more than 25 millimeters, and mean diameter of 3, or coronal plump, more than 7 millimeters, and no visible heartbeat. So how to manage this patient? Of course, it's always safe to get a woman for follow-up, even if you have the criteria for miscarriage at the first examination, particularly for less experienced examiners. It's always advisable to take women in follow-up, and particularly in those that we, of course, do not reach criteria, we cannot see conclusive diagnosis of miscarriage. Take patient in follow-up in 10 to 14 days or in 11 to 14 days. Because, as I've shown you, there is a biological variation of growth of mean gestational sac and also CRL, and it overlaps in viable and non-viable pregnancies, and follow-up always is safe. And if we at follow-up at least 14 days, in case of earlier empty gestational sac, we do not see any heartbeat today, we can say that the diagnosis of non-viable intrauterine pregnancy is conclusive. And if visible yolk sac was during the first ultrasound examination, and we do not see any heartbeat at least at the next scan at least 11 days later, we can see that this is a conclusive diagnosis of non-viable pregnancy. And very shortly about how to manage when we have a conclusive diagnosis, we have to choose between expectant management. We can choose the medical treatment, misoprostol, or in combination misoprostol and mifepristone, or surgical evacuation, which is probably not the first method we advise for the patient. And just to show you very shortly, a randomized double-blind placebo-controlled trial where mifepristone was and misoprostol was used versus misoprostol alone, and in total 2,746 women assessed for eligibility, and randomized total is 711, and with primary outcome available 348 in each arm. And there were randomizations 1-to-1, and in the first group, women received mifepristone, and thereafter single dose of misoprostol, sublingual, oral, or vaginal. And in the second arm, it was a placebo instead of mifepristone, and also the same for the misoprostol that has been administered 2 days later. So just show you very shortly about the primary outcome was set for the failure to pass the gestational sac spontaneously within 7 days after random assignment, and we can see that women that received placebo plus misoprostol were more likely to fail to pass the gestational sac spontaneously within 7 days compared to those that got the combined treatment. And for the secondary outcome, which was surgical intervention to complete miscarriage, we can see that more women in the placebo group required a surgical intervention. And we can also see for the secondary outcomes that the outcomes were very similar between the groups. And it has been concluded that mifepristone and misoprostol was more effective than misoprostol alone in management of miscarriage. Just a couple of slides to finalize my presentation. We scan patients at the different gestational weeks. We scan patients at sometimes very early pregnancy. Be very careful. Look for the structures, but also look for the location of the pregnancy. We can see this is a very early pregnancy, probably with a very small gestational sac inside. Here we have also an early pregnancy with a gestational sac, but we can see clearly that this pregnancy is located in the pregnancy scar. Here we have another case where we can also see that we have some small structure intrauterine, and we have talked about the ectopic pregnancies. We have to know that the true gestational sac is located eccentrically and should have a hyperechoic rim. And of course, if we see something, we have to complete our scan to be systematic, because here in this case, we had saw a very small cystic structure, which was not a true gestational sac, but we could see instead an ectopic pregnancy around. So just be careful, don't blame all pregnancies for miscarriages. We have to still search for probable pregnancies anywhere. Here we have a pregnancy in the cervix, for example. So do your systematic scan and assess in the systematic manner if you see a structure that you believe it's a miscarriage. So what are the lessons of my lecture? I have told you about the current ultrasound criteria for non-viable pregnancy, that is empty gestational sac of 25 millimeter or more in mean diameter of 3, or CRL more than 7 millimeters without heartbeat. And remember how to take correct measurements of the gestational sac. And in case if its viability is unclear, or you see an unviable pregnancy, in particular in the hands of less experienced examiners, follow-up might be useful in 11 to 14 days, and it is safe. Thank you so much.